Hi everybody, welcome to my latest webinar. My name is Professor Paul Tipton. I am the Clinical Director of Tipton Training Limited. As it shows on the slide, President of the British Academy of Restorative Dentistry and a specialist in prosthodontics. What I aim to do today is to give you a webinar based on A to Z of smile design. So without further ado, let's get into it and let's start going. So first off, two important books. If you're interested in smile design and you would like to learn more from learning how to design a smile and also in terms of how to discuss this with your patients, then these are two excellent books, and especially the one which I've just highlighted here, Change Your Smile by Ron Goldstein. Ron Goldstein is the grandfather, if you like, of smile design dentistry, cosmetic dentistry from the States, and he's written an excellent book. It's an excellent book in terms of you understanding what smile design is all about, and also about you integrating it into your practice. And it's an excellent book for your nurses, for your receptionists to also read, because it goes in depth into smile design from a patient perspective, but there's still a lot for us to learn from a dental perspective as well. Let's look at our base of patients. So this is a very interesting slide, and it tells us how we should be talking to patients. So the basics of this slide say 4 out of 10 people are not happy with their smiles. 8 out of 10 desire a change of their smiles. So again, on the theme of marketing and talking to our patients, this would initially make you think that 4 out of 10 people want smile design dentistry, want cosmetic dentistry. Okay, but this is all about the questions you ask, and it's so important that you ask the right questions of your patients. So if you ask the question of your patient when the patient comes in, are you happy with your smile? 4 out of 10 will say that they are not happy with their smile. 6 out of 10 will probably shrug their shoulders and say, yeah, I'm kind of happy with my smile. So that's 40% of your patients who are likely to say, I'm not happy with my smile. And therefore 40% of your patients are going to be the ones that you can then go and treat. Now, what happens if we ask a different question? And this is really, really important. So rather than saying, are you happy with your smile? Why don't you ask them, what is it about your smile that you're unhappy about? What is it about your smile that you do not like? And then, so the studies would tell us, 8 out of 10 would say there is something about their smile that they don't like. Now what's happened is we have doubled the number of patients who potentially would want treatment. So in terms of doing the smile design dentistry, the cosmetic dentistry, yes, we need to understand everything about it, how we do it. But we also need to make sure that we mark it correctly to our patients. And then we can double the amount of work that we do. So very, very important slide on the right questions to say. And of course, it's driven by the media. We've got a couple of stars here, David Bowie, Catherine Zeta-Jones. Both of them had cosmetic dentistry done. Both of them posted photos of their new smiles. So everything is pushed, of course, by the media. And that leads us on now to talking about some of the actual concepts of smile design. So if we look at this lovely lady, so a pretty looking lady, okay, first of all, let's look at beauty. Rather than just looking at teeth and smiles, let's look at beauty overall. And what do we know? What creates a beautiful face? That's the first question. And there are several concepts that create a beautiful face. The most important two, and the two that spring to mind, are making sure that you've got symmetry and also proportion. Those are two very, very big words in smile design dentistry. So the first thing is that we've got symmetry across the midline. So what makes a beautiful face, starting off, is that the right hand side and the left hand side are symmetrical. It's exactly the same from a smile. We need to make sure that the right hand side and left hand side are symmetrical. Now we can go overboard on this, and we can make them so they are exactly the same. And if we go and make them exactly the same, then that really will produce a cosmetic appearance as opposed to an aesthetic appearance. There's a subtle difference between the two. Aesthetic dentistry is enhancing nature. Cosmetic dentistry is replacing nature. And it all depends on what type of smile your patient wants. But our starting point is the center line. And we'll talk a little bit more about that in just a second, and making sure we have symmetry. Second important part is the occlusal plane. So we need to make sure that our center line that goes between the center of the eyes, center of the nose, center of the mouth, center of the teeth, etc., is also perpendicular to two other lines. Okay, and those two other lines are the anterior occlusal plane and also the intercommissure line. Very, very important. Otherwise, what we get is a slanted smile, and we have our teeth at an angle, and therefore that doesn't create the right appearance. So we need to ensure that our anterior occlusal plane is parallel to the eyes. A brief warning, sometimes we do it parallel to another line, and I'll come back to that in just a second. Next thing is proportion. So we talked about symmetry, now let's look at proportion. And it's really, really important, proportion-wise, that we get the face into thirds. So the hairline to bridge of nose to base of nose to chin when the patient smiles should be equal thirds. Now, what do we know? We know that this particular part, okay, sorry about that, guys, we're back in position again. So we're talking about facial thirds, and the fact that hairline, bridge of nose, base of nose to chin should be equal thirds. So we have a huge opportunity in dentistry, because what we do now is we're able to influence that lower third of the face. And we can influence that by increasing or decreasing vertical dimension. Now, vertical dimension is a complete topic on its own, and I've done webinars on that previously, so I'm not going to have the time to spend too much with you on what we do about increasing or decreasing vertical dimension. Few salient points, however. If you're going to increase or decrease vertical dimension, you have to do it around RAP. That's the first thing. Okay, so your condyles have to be in the right position. You have to make sure that your muscles are nice and relaxed. And then we go and build the teeth together at that increased vertical dimension. And what we can do, we can now create a beautiful smile, but also have a huge impact on facial form. Huge impact that will give the patients almost a dental facelift. We can increase their nose-chin distance. This will make the corners of the mouth and all the wrinkles less obvious, and we can put them back into proportion. So symmetry, proportion, two of the biggest words that we can deal with smile design dentistry. So this leads us on to our first type of smile. The first type of smile is the media smile. Now, the media smile is, first of all, what every patient thinks that they want. They want the dazzling white smile. So let's see what this media smile actually entails. As you can read it yourself, the media smile is characterized by white teeth, overtly white teeth that are whiter than normal. Beautifully aligned teeth, so they are totally symmetrical. With an absence of gingival incisal embrasures, which means the teeth are very, very long. And this is what your typical appearance of cosmetic dentistry brings you. And again, the media, these smiles are rife with the media. Here we have a smile by Halle Berry, and all the teeth symmetrical, the right hand, left hand side equally the same, overtly white, there's no color there whatsoever. Another picture, the same dentist who did these teeth, again, overtly white, etc. Now, that's fine for some patients, but we're going to talk also about a natural smile and how to take that media smile and tone it down a little bit for some patients who don't want the media smile. The media smile is very much for that person that wants to show off. He wants to show off to say, look at me, look at my smile. I've had it redone. I've got a mouth full of veneers or crowns. Look at me. It draws attention to my smile. The natural smile is much more subtle. Some patients want the media, some patients want the natural smile. And part and parcel of the communication process between ourselves and the patient is finding out what type of smile they in fact do want. So let's look at a patient here. And let's talk now about marketing, yes, but how we get our points across to our patient. So this patient is an actress in the UK. Her name is Julie Peasgood, and she's appeared in very many number of programs. And let's try and first of all look at the smile and diagnose what is potentially wrong with it. Okay, so she comes to me and several things that she's not happy about, and we discuss. And the first obvious things that you will see is the center line is slanted. You will see that there is a maxillary cant, so that the teeth on the right hand side appear longer than the teeth on the left hand side. The lip is short of the teeth on the left hand side. The lip is overlapping the teeth on the right hand side. The gum, there's too much gum showing on the upper right hand side and maybe not enough gum showing on the upper left hand side. So straight away, symmetry is wrong. You may well go and say that the lips are very thin, and by today's standards with lip enhancements and things like that, yes they are. If you look very closely at the upper left hand side, you may see some gingival recession, you may see some abstraction lesions. Look at the upper right central incisor, and what do we see there? We see some gum inflammation, probably an old crown which has got a poor gum margin. Look at both laterals. What strikes you about both laterals? They're a little bit on the wide side. The golden proportion isn't correct. The gingival margins are higher than the canines. Are they actually canines behind, or are they first premolars? And are the laterals, in fact, disguised to look like canines? So overall, there's an awful lot that's going on in this mouth, and there's an awful lot that we can now talk to our patient about in terms of how we put this right. So how do we now talk to the patient? What do we say to the patient? Do we say to the patient that I would advise you to have a gum lift on the upper right hand side, to have some gum taken from your palate and put onto the upper left hand side to bring the gum down? We're going to make your teeth shorter on the right, longer on the left. We're going to go and change the canted maxilla so it's not canted, change the center line, etc. That's very difficult to get across to the patient in words. However, what you can do is use something called cosmetic imaging. So let's have a look at this. This is now our cosmetic imaging. So this is our patient now, where we've taken before photos, and I've taken 2 before photos. One we've left on its own, as you can see in front of you, and on the other one we've gone and performed some cosmetic imaging. So we've gone and done our smile design, our smile makeover, but on a photograph. And what does the patient see now? You put yourself in the patient's frame of mind. What the patient sees is a lovely, beautiful smile. And the patient says to herself, I want that. So it's not a matter of you trying to say, we do gum lifts here, gum lifts there, and maybe the patient thinking, I'm not too sure what this will look like. By showing her the end result, from a marketing tool, and I'll show you again in the treatment planning tool in a minute, from a marketing point of view, she says, that's a beautiful smile, I want that. And as long as you can actually go and achieve that for the patient, then you've got patient acceptance. You've got a patient ready to go. Let's look at another case. Another case this time, not so much of marketing, but also of treatment planning. How do we treatment plan a case like this? So first of all, let's look at her face. She's a good-looking lady, about 40. You can see her teeth aren't particularly nice at this present stage. Let's look a little bit closer at her smile. You can see that the center line is off. She's got restorative dentistry that's been done. Let's reflect the lips, and here you can see the smile. So we've got a bridge on the upper left-hand side, no bridge on the upper right-hand side. So straight away you can see that we've got, just tap that, just here on the upper left 2, we've got an extra tooth. On the upper right 2 area, there's no tooth. So in terms of symmetry, we've got a huge problem, because we've got 1 extra tooth on the upper left hand side and we're missing a tooth on the upper right hand side. So we go back to that first slide, symmetry. We'll look at proportion again a little bit later, but symmetry. How do I now create symmetry across the midline? How do I create the midline? So I can create symmetry one of 2 basic ways. The first way is to go and take the upper left lateral out, move the upper left central across to the left hand side, try and make the upper left canine look like a lateral incisor, make the upper left premolar look like a canine. So I can do all those sorts of things. Secondly, what I can do is, rather than removing the upper left lateral incisor, I can go and replace a lateral incisor into the right hand side between the central and the canine. So basically my achieving symmetry is involving either removing a lateral incisor one side of the mouth or adding a lateral incisor the other side of the mouth. But we've got to create symmetry. Okay, now by doing that, what will happen? Several things will happen. First of all, if I add an extra lateral incisor into the right hand side, we're going to have one extra tooth in the whole setup. So that means that all the teeth that we now put back are all going to have to be a little bit thinner. If I take the lateral incisor away, where it is at the moment, in the pontic area, take that away and move the central incisor across to the left hand side, that means that all my teeth, to fill the space, all my teeth are going to be a little bit wider. So I can create symmetry, but straight away I've got two alternatives. Do I create symmetry with an extra tooth, putting it back? Do I create symmetry by taking one of the teeth away? So if I create symmetry by putting an extra tooth back, all my teeth will be a little bit thinner. If I create symmetry by putting an extra taking a tooth away, all my teeth will be a little bit wider. Which one does the patient want? How can I put this across to the patient? Only way I can put this across to the patient is by showing her photographs. Okay, and here's three different photographs. The first one over here on the right hand side. Let's see if I can get this pointer working again. Okay, now I'm struggling to get this pointer moving. Okay, so the photo that you see looking at the screen, the left-hand side one, okay, the left-hand side, this is where we see all the teeth in the smile, but slightly wider. The next one across here is where we see all the teeth in the smile, but slightly thinner. The next one that we see is where we see all the teeth in the smile, but what we've done is flipped. So we've taken the extra lateral incisor, which is in the upper left 2 region, and we put it to the upper right 2 region. And the final picture is where we've now gone and said, this is where we would do orthodontics maybe to create the most beautiful smile. So we're into a compromise. And just to show you again, the compromise, the first photo is having the teeth a little bit wider. The second photo is having the teeth a little bit thinner, so we're putting an extra tooth in there. Third photo is flipping round. So the upper left 2 has moved to the upper right 2. And by doing that, we've at least created the correct center line. So my question to you, which one of those would you prefer? Number 1, number 2, or number 3? Which would your patient prefer? How could you actually go and achieve that with your patient without showing her the photos first? And what happened was the patient chose number 2, the extra teeth. This was her smile then at the end. So we managed to go and take the upper left lateral incisor and produce another upper right lateral incisor in its place. So we created symmetry across the midline. All the teeth are a little bit thinner, but we've created something which is hopefully a very, very nice smile. And that's basically how we now go and design our smiles. Let's look at another case. Another lady here, an older lady. We look at her teeth. They're slightly worn, they're slightly crooked. We've done the cosmetic imaging, as you can see on the second photo. We look at her at the side. This is now profile. And what I'm doing between the photos is I'm increasing vertical dimension. So the photo on the right hand side is increased vertical dimension by about 5 millimeters. Again, the pictures here on the left hand side of the screen is her normal vertical dimension. On the right hand side is her increased vertical dimension. You'll notice she's less chinny. when the jaw drops back, it also creates more of a class 1 occlusion. So we've decided facially that this is something that we want to do to open up the vertical dimension. We now go and look at her teeth, and as you can see, her teeth are worn. Not a very nice color. The occlusal plane is completely up and down, and she's got lots and lots of restoration. So she needs a full mouth reconstruction of some sort. So we're going to go off and do the full mouth reconstruction, and we're doing it in this instance in zirconia, and we're doing it with absolutely white teeth. She wants to have that complete media smile. And we take her from here. We're going to lengthen the teeth so we give her more lip support. We're going to give her so when her lips are at rest, she sees a little bit more teeth. And there's the final result. Very opaquely white, because that's what she wants. Right hand side and left hand side symmetrical, long contact areas, minimal gingival embrasures, everything that we've discussed already about the media smile. Again, another shot, and here's her final smile. And before and after, and I think the things that you will see from this slide is she looks thinner in the face. Why does she look thinner in the face? Because we've increased her vertical dimension, and therefore she looks more in proportion, she looks thinner. So it looks to me as though we've probably taken 5 or 10 years away from her in terms of her appearance, her age, and she looks much nicer, much better. It also improves psychology. Now remember this, we're not just dealing with smiles here, we're dealing with a person, we're dealing with a patient. Okay, and that means to her, not just she's got a better smile, she feels better about herself. Psychologically, she feels good. She's going to go to the gym. She's going to work out a little bit more. She's going to look at better foods, eating better, eating more healthy. And that's what we have done by creating a better smile, by enhancing facial proportions. We are now changing these people's lives, changing them for the better. So we mentioned media smile. Let's go and look now at how we tone that down and how we create a more natural smile. And the first thing we can do is shade progression. So have a look at this particular slide here. With the media smile, all the teeth going from central incisor to lateral to canine, etc., all the way backwards are all the same color. Also, the teeth going from gingival margin to incisal edge, all the same color. Now that's cosmetic dentistry. That is not normal. If we want aesthetic dentistry, then we need to try to create something that's a little bit more natural. And that means that as we go from front to back, the teeth get slightly darker. As we go from gingival to incisal, the teeth go from a more yellowish color to a more creamy, to a whiter, to a grayer appearance at the incisal edge. So it's all this which we call shade progression, which starts to make a beautiful smile, but a more natural looking smile. And if you maybe have problems getting this over to your patients, then what I do is I take photos from magazines of celebrities, and I know this doesn't recreate it that well here at the moment, but if you did look at some of the canine teeth, and the Kate Winslet canine tooth is slightly darker, the Jennifer Aniston canine is darker, the J-Lo canine is darker. And again, you can probably see it more a little bit better on the right hand slide here, the close-up, and it's the canine which is the giveaway to most smiles. If you can create a more natural smile, then you create it with the canine. I seem to have lost my appearance. I don't seem to be talking. You just got a basic photo of me. I don't know if that'll catch up, but anyway, let's concentrate on the slides. So shade progression is basically central incisor. Let's just say that we choose our ideal central incisor. And our ideal color central incisor in this instance is A1. Our lateral incisors then would be A1.5. Our canines would be A3. Our premolars A2. So you can see that we go from central to lateral half a shade darker. Canines 2 shades darker, premolar 1 shade darker. This creates a natural appearance. If we don't want anything quite as natural as that, then maybe we have the centrals and laterals at A1. Sorry about that, guys. Again, the screen seems to have frozen. So we're moving on. We're moving on to specific aspects of smile design. The first specific aspect is centerline. And of course, the question is, where do we put the centerline? So if we look at the science of this, we see that the centerline, the dental midline, coincides with the median line of the face in only 70% of our population. We also know there's just over a 50% chance that a 2mm center line discrepancy will not be noticed. Now, this is an important slide. What this says is that the center line does not have to coincide with the ideal center line of the face, but be approximately up to 2mm off before patients will notice. So sometimes it's impossible for us to get the center line exactly right. But if we can get within 2mm of the exact correct position, then over 50% of our patients won't actually notice. And of course, the most famous, I suppose, centerline discrepancy that we see day in, day out on all of our films, etc., is, of course, Tom Cruise. And he's got an awful, his centerline's at least one central incisor out of sync. So where do we place this center line? We place the center line ideally in the facial midline, but most importantly in the center of the lip. So we look at the red line and the black line here. The red line is the center of the face. The black line is the center of the lip. And you can see the center line still 3 to 4 millimeters off from both of those. Which center line do we choose? Because most of my patients aren't totally symmetrical. Most of my patients aren't models, and therefore I need to choose a center line. And the logic says, choose the center line which is closest to the next anatomical landmark. So the anatomical landmark, which you can see here, is the lips. So put the center line in the center of the upper lip, so that when the patient smiles and we look at that smile, we can see that the center line coincides with the center of the upper lip. And so that is the black line. So the maxillary midline must be related to a specific facial landmark, the most reliable of which is the center of the upper lip. And here's some cosmetic imaging done of Tom Cruise, where again we've gone and placed his new smile in the center of his face, in the center of the upper lip. Now, what is more important than the mediolateral position is the verticality of it. And this means that the center line has got to be at 90 degrees to either the interpupillary line or intercommissure line. So it must not be slanted. That is much more important. And the dental midline perpendicular to the interpupillary line is one of the most striking contrasts, and it serves to anchor the smile on the face. So let's look at a particular case study here, and we can see from the before photos here that we've got a center line discrepancy. It's not the same. Upper center line isn't coinciding with the lower center line, and we've also got a verticality problem. It's slanted to the left-hand side. The teeth on the upper right are hanging down, so we've got a maxillary cant. How do we go about treating this case? First thing, diagnostic wax up. So we take our mounted study casts, same way that we approach every single case. Mounted study casts, diagnostic wax up, create the correct center line. From that, we now design our prototype restorations. We design our tooth preparation guide that goes over the top. And we now use our tooth preparation guide to guide us to the correct tooth preparation. So here it is in the mouth. I've placed several holes in the tooth preparation guide, and I can probe through with my periodontal probe so that I can tell what the depth is of the tooth tissue which I'm preparing from the undersurface of my tooth preparation guide. And in this instance, I want to go with zirconia, so I want approximately 1 millimeter of space between my tooth prep guide and the actual tooth preparation. So I've finished my tooth preparations. I've created an ovate pontic site for the canine. I'm putting my prototypes in place, and straight away we've now got the correct center line. It's not leaning to one side. It's also perpendicular to the incisal edges. And we go and change that now into the definitives. So once we've got our prototypes right, we just copy into the definitives. And our final beautiful smile. Next thing to talk about is incisal plane. And what do we mean by incisal plane? The incisal plane is an imaginary line which connects the incisal edges of the two central incisors, another imaginary line that connects the two laterals, the tips of the canines. All those parallel lines are at different levels, and they should all be parallel to either the interpupillary line or the intercommissure line. And then the smile line is the curved line which flows and follows the tip of the canine to the incisal edge of the lateral, to the incisal edge of the central, and that then produces a curve. So in this instance, our smile line are the incisal edges parallel to the eyes, and our incisal plane is, and our smile line is the gentle curvature. So we've mentioned straight away that our incisal plane should be parallel to the eyes. What do we see here? We see the incisal plane and we see that it's not parallel to the eyes. So what's the problem? The problem is that the lower third of the face is canted, not just the maxilla now, but the lips are canted. Imagine what would happen if you fell into the trap of placing some veneers or crowns that were now parallel to the interpupillary line. What would happen? What would happen would be that you'd show more tooth on the left-hand side and we'd show less tooth on the other side. So we'd have an unsymmetrical situation where we're showing more tooth on one side, less tooth on the other side. And that's a huge problem to us because of, as we mentioned, symmetry. I want symmetry. I want symmetry between this side and this side. And if now my occlusal plane is parallel to the eyes, I'm going to show far more tooth on the left-hand side and far less tooth on the right-hand side. And this is all because of we've got a facial cat. So what do we do in these situations? In these situations, we have to go now and make sure that the incisal edges are parallel to the intercommissure line. So always look out. With a patient who's going to go through cosmetic dentistry, always look and check that the intercommissure line is parallel to the interpupillary line. If it is not, then we choose the intercommissure line. Again, why? Because it's the closest anatomical landmark. If the two are parallel to each other, then we can choose either line. It doesn't really matter. How do we give this to the technician? It's important that we now decide and show the technician these two lines. So this is a nurse of mine, and this is Lisa, and I'm doing a face bow on Lisa. And the first thing you notice on Lisa is that the face bow here is not parallel to the eyes. What this will mean is when I mount my models, the models will be parallel to the top part of the articulator, and therefore my technician will naturally do the incisal edges parallel to the top part of the articulator. When I come to put these in the mouth, then the incisal edges will be parallel to that face bow. So straight away I will have a cant and my incisal plane will not be correct. So if I'm going to use a face bow, I need to make sure that we make our face bow so that the face bow is parallel to the eyes. So what do we do there? We push down one side, push up the other side, and we get the face bow parallel to the eyes. Now, when our technician does the crown work, he does the crowns parallel to the top part of the articulator, and of course the top part of the articulator in this case is going to be parallel to the eyes, so the incisal edges come out exactly in the right position. Another way of doing this is by using a stick bite. So you can see those lines now. Those lines have got to line up with each other. Otherwise, we use a stick bite. So here's another case where we've got a canted maxilla, and you can see that the edges are going upwards here, and our patient doesn't like the smile. What are we going to do about it? First thing we mentioned earlier, mounted study cast number 1. Number 2, diagnostic wax up. Number 3, preparation guide. Number 4, prototypes. Number 5 stage, let's get into the mouth. Let us take off the old restorations. using our preparation guide. Number 6, let's refine our preparations. In this instance, we've changed the post to cores because we're going to be using some translucent porcelain. We now take our impressions, we put our prototypes in place, and you can see straight away that our prototypes are now, all the incisal edges are parallel. We don't have that cant. We have a center line which is perpendicular to the incisal edges, and we go and then transfer the prototypes to our definitive restorations. And here's our view of the definitive restorations. Center line in the right position, incisal edges in the right position, smile line correct, and of course we have one happy patient. Next thing we mentioned, again, smile line. Smile line is a curve. And what do we know about the smile line? We know from the smile line that it becomes more curved as we're younger. It gets flatter as we're older. It also becomes flatter in the male, more curved in the female. So straight lines are acceptable for males, but not for females. So here's George Clooney with a very, very flat smile line. It goes flat across. It doesn't follow the lower lip, but this is acceptable for males. If you were to go and do a male with a very curved smile line that followed the lower lip, it would look totally false. It would look too feminine. So here we have a gentleman, and let's go through another case with you. He doesn't smile much, and he doesn't smile much because when we look at him, he's got some very, very worn teeth. We go and do our cosmetic imaging, as we've suggested. These are his flat teeth. We do a little bit of tooth whitening first of all, so that again we're going to put some translucent crowns in place. We're using face bow mounted study casts initially, and here's our diagnostic wax up. We're now going to be doing crowns from upper left 5 to upper right 5, not the 6s and 7s, and we've got our prototypes here made as well. And the difference in this case is that I'm going to open up the vertical just on the anterior teeth. And this, of course, is the Dahl effect. And what I'm going to do when I open up the vertical dimension and put the prototypes in place, these are my preparations. Now we put the prototypes in place and we do our shades, but we ask our patient now to close together. And because we've opened him up, the mandibles drop back. We've got an overbite and overjet. Yes, the 6s and 7s are not actually in contact, but we're going to be waiting for those 6s and 7s to over erupt, and that will take probably about 3 months. We're not opening him up too much. We've opened him up by about 3 millimeters at the incisal pin, which means that we only are waiting for 0.5 millimeter over eruption of the upper tooth, upper 6 and upper 7, and 0.5 millimeter of the lower 6 and 7. So within about 3 months, those teeth will be in contact. And this is the Dahl concept that we talk about. We talk an awful lot about this in Europe. So we've now created a beautiful class 1 occlusal scheme. We're creating a smile line with a small degree of curvature, not too much, not the female part, slightly flattish, just a small degree of curvature, which of course is a typical male look. We then transfer that into the definitive porcelain, and because he's been a natural grinder, he's flattened his teeth because of his clenching and grinding. We've put a maxillary occlusal splint in place to stop him from grinding and clenching and chipping away at my lovely crowns. So here's his final result. Slight curvature, not too much curvature. Too much curvature would look too much female. So flat incisal plane, acceptable for older age group, also for males. But what we mustn't do is have a great deal of curvature for a female. This is a TV personality in the UK called Cilla Black, and she has too much curvature. Look at the curvature from here to there, far too much, and it looks totally false. So for a female, we have to have, again, a female that's older, a flatter anterior occlusal plane. Younger female, a more rounded occlusal plane. So we have a lady here who's got a reverse smile line, and we look at closer view. You can see that from the canine here to the canine here and to the centrals, that is, rather than being a convex curve, it's a concave curve. So it means that these central and lateral incisors are far too short. So we're going to have to lengthen them, but not lengthen them till they're too much longer than the canines. Remember, this is an old patient, so I'm going to lengthen them till they're more or less the same length as the canines, giving a very, very small amount of curvature there to match the lower lip, not too much. So we start off in our same normal way, mounted study casts, diagnostic wax up. This is a view of the incisal edges. We prepare the teeth. These are 3/4 crown style veneers. And we prepare our teeth. We go and dentine bond any exposed dentine immediately to hybridize the dentine. We take our impressions, fit our prototypes, and you can see straight away with the prototypes, the incisal edges are more or less the same length as the canine tips, so as not to give too much curvature there. And we're into the laboratory now and creating our definitive veneers. And here's our definitive veneers. Now made 4 veneers, a natural appearance for this lady because she's in her 60s. She doesn't want something that's overtly white. And here again, we've got the canines, laterals, centrals, very small degree of curvature, which is exactly right for an older person. And we look at the overall photo and it looks neat, it looks natural, it falls in with her face as opposed to the picture of Syllabac previously. Contact points. What do we know about contact points? Okay, we know about contact points that the contact point should line up. The center of the contact area between the anterior teeth should line up on a curve that reinforces the curvature of the lower lip. We also know that for females, we have more incisal embrasures, and for males, less incisal embrasures. And we know about the 50-40-30 rule. So important, the 50-40-30. So have a close look at this slide. The connector between 2 central incisors should be 50% of the length of the central incisor. So let's look at this picture. Charlotte Johansson, another very pretty actress, and we look very closely. And what do we see? The connector length between the 2 centrals is 50% of the length of a central. As we go from central to lateral, the connector length now between central and lateral should be 40% of the length of a central. As we move out towards the canine, the connector length between the lateral and the canine should be 30% of the length of a central incisor. And this will give us a beautiful looking smile. We also need to know about golden proportion. And have a look at this photo. What's wrong with this photo? Sometimes you can't really go and put your finger on it, but it's a proportion thing. So if you look at a smile, if you look at maybe some models, you look at some crowns you've had done, and it's lying on a lab bench and it doesn't look quite right. If it doesn't look quite right, you can't put your finger on it. It's a proportion problem. And we know that our golden proportion is the way that we can tie up and make sure that all the teeth are in exactly the right size in relationship to them. And our golden proportion is 1.6 to 1, which means that the proportion of central to lateral to canine in terms of width will be 1.6 to 0.6. Now, of course, this isn't the natural width. This is the 2-dimensional width that we would see if we looked on a photograph. Okay, 2 dimensions, we're not looking round a curve, we're looking purely a 2-dimensional flat photo. And of course, the canine is wider than the lateral incisor in natural light. But as we look in 2 dimensions at the front, the lateral appears to be wider. So this is the ideal proportion to our front teeth. And this is showing it. So we've got 1.6 to 1 to 0.6. So look at the width here, the width there, and the width there. That's 1.6 to 1 to 0.6. Another way of looking at it is 1.6 to 1, 1.6 to 1, 1.6 to 1. So as we go further back, we show less and less tooth at the front when we smile in that same proportion of 1.6 to 1. You can get golden proportion calipers, and these are calipers which are very, very useful to get because that will allow us to look at teeth and to show, and here's a beautiful smile, a natural smile, and straight away you can see that the central incisor width to the lateral is 1.6 to 1, We can look at magazines and we can check all this out. Okay, we now have a case. A young lady goes off for orthodontics when she's young. She has the canine pulled down. At the moment, you can see that the canine is impacted. She has the canine pulled down into her mouth, so it's going to come down into here. And she has her orthodontics. It takes approximately 2 years. She then goes off to university. She comes back from university and she says that she doesn't like the gaps between her teeth. And you can see straight away the width of the lateral incisor here. The central incisors are far too thin. The central incisors need to be wider. So we have a golden proportion problem between central and lateral. Hence, we're now going to do some veneers for her. And when we do our veneers, we're going to add a little bit of material onto each of these different areas to make the teeth slightly wider and put her back in the golden proportion. So we do our preparations. We try to equalize the gaps. We have a big gap here, small gap there. So we try to equalize them by doing a little bit more tooth preparation on one side than on the other side. Exactly the same on the other side, where we've got a bigger gap here, smaller gap there, a little bit more tooth preparation here, a little bit less tooth preparation there, and suddenly the gaps become very, very similar. This way, we're always sort of looking to align the preparations to make it easier for our technician. We take our impressions, we put our prototypes in place. Our technician now uses a Geller model to go and complete the work. And here's our stone dies in our acrylic model. That's what a Geller model is, stone dies in an acrylic model. We're now going to trim the interdental papillae so that they go from being broad and wide into a nice thin papilla, which you can see just there. We do that both sides, which allows our technician now to make the veneers with a nice thin interdental papilla, with the contact areas the right length, 50% of the length, 40% of the length of the central, 30% of the length of the central. And by the time these are now fitted into the mouth, we have the gaps closed off, but we also, more importantly, have the correct golden proportion. The width of the central to the width of the lateral, 1.6 to 1. If we're to put the calipers on, the width of the lateral to width of the canine, 1.6 to 1. So to get ideal looking teeth set up, we have to use the golden proportion. It's used many ways. Another way of looking at golden proportion is the width of two centrals to the length of a central should be in the golden proportion. So there's lots of ways that we can use this golden proportion. And our final result. Next thing to look at, incisal length. How long should central incisors be? Well, they range from 9 to 12 millimeters. You look at different studies, 10.4 to 11.2. What else do we know about them? The maxillary canines and central incisors are the same length. They're at a different level, but they're the same length. So if we're ever missing centrals, measure the length of the canines. That's what we're looking at here. If we're doing an anterior bridge, whereabouts should the centrals go? Anteroposteriorly, incisogingivally, whereabouts should they be? We need to have some indication. We need to understand what central incisors look like. Another one, the base of the sulcus to the incisal edge, 22 millimeters. So we have lots of information, and the incisal length, if we make it too long, it doesn't look right. Patient looks false. If we make it too short, patient doesn't show enough tooth and he looks old. So it's really, really important that we show the correct amount of tooth underneath the lip, because these are the primary determinants, if you like, of the age and sex of the patient. So we look at beautiful models, and the first thing that we see with a beautiful model, this is Linda Evangelista. How much tooth tissue is she showing? She's showing over half the central incisor there. So that's probably about 6 millimeters. We'll look at another model, Claudia Schiffer. How much is she showing with her lips at rest? Lips at rest, this is the important thing, not when she's smiling, lips at rest. Again, 5 to 6 millimeters. So Gerard Cheesh in his book suggested 3.5 to 4.5 millimeters for young females, men 40% less. But this is 1994. Lipstick adverts, trends come in, and now you can add a millimeter onto that. 4.5 to 5.5 for young females, 40% less for males. Again, Kylie Minogue showing probably 7 to 8 millimeters of tooth tissue underneath the lip. So important that we understand what happens to the amount of tooth tissue that we show with age. So here's a nice graph that shows when we're young, we show a lot of upper tooth, minimal lower tooth. But what happens with our lips at rest as we get older? We show lots of lower tooth and very minimal upper tooth. So really important that we can understand what is nature. This is nature. And if needs be, we can improve upon it. So I can take somebody who is 60 years of age, and she says, I want to look 10 years younger with my smile. What do we do? Well, we actually go and decrease by about half a millimeter, the amount of lower tooth that she shows when her lips are at rest, and we increase by about half a millimeter the amount of upper tooth she shows with the lips at rest. Again, we take a 50-year-old and take her to 40. We go and take her from 2 millimeters of lower tooth showing to 0.8, from 1 millimeter of upper tooth showing to 1.5 millimeters. So this way we can make a smile look younger or older. Moving on, not got too much to go now. Looking at incisal profile. So what does incisal profile means? It means whereabouts labiopalatally should that central incisor be. And the way that we look at profiles is evaluating this very often by phonetics. And as you can see here, E is maximum smile, M incisal display, F or V incisal edge position. And it's the F and V when the patient makes these words that will define how far forwards we can bring the labial aspect and the incisal edge. Remember, the further I bring it forward, the more lip support we have. And if I've got an older patient, a patient of a certain age, maybe a 40, 50-year-old that wants to look younger, we need to bring those teeth forward slightly to give more lip support. When I get more lip support, the lip everts, it becomes shorter, and we show more upper tooth with the lips at rest. So overall, a very, very positive appearance. And this is our nurse, Jane, now making the F and V sound. So here we have a lady of a certain age. You look at her teeth, and they're worn. She wants a general smile makeover. This is what we see from the upper occlusal view. We have premolars which are palatally in place, so it doesn't even look as though she can see those. So we look as though we've got gaps here and here when the patient smiles. She wants a general improvement in her smile, so we're doing some veneers for her. We're putting her prototypes on, and what we're doing is we're bringing those prototypes forwards by about 1 millimeter. And by doing that, the lip everts, the lip becomes shorter, it becomes fuller. We've improved the overall length of these teeth. We have a nice smile line, incisal edges parallel to the eyes, and there's our final end result. We've gone from a very flat appearance, worn teeth, not long enough, to a longer appearance of the teeth, not worn as much, a nice rounded appearance, not too much of a smile line, not too much curvature there, because if there's too much curvature, it looks false. And at the end of the day, we've taken our patient from this appearance to this appearance. She looks younger, she looks as though she's improved her appearance generally. Now, our final topic, maxillary teeth. And then we're going to call it a day. We're going to look at centrals, we're going to look at laterals. And of course, there's much more to smile design than this. This is me running through some of the basics. So, what does a central incisor look like? It's got a deep bulge, it's got a deep curve here, and we've got a flat emergence profile. Average length, we've already mentioned. Widths, 8.4 to 9.3 millimeters. Pleasing width to length ratio, 75 to 80%. It's the starting point. Our central incisors are the starting point. So we need to get central incisors right. So what's wrong with this smile? First of all, the central incisors don't look like centrals. We've not got the right golden proportion. The canines are too bulky. We look a little bit closer. Width to length ratio is completely wrong, not 75 to 80%. And so we need to go and redo these crowns and put them so that they look like natural centrals, natural lateral incisors. And look at this, rather than being 1.6 to 1, we're 1.2 to 1. So the teeth are either too long or not wide enough. So starting point, as ever, mounted study casts, diagnostic wax up, the prototypes as in this stage. We now go and get our prototypes made, our preparation guides here, use those in the mouth, as you can see, to probe through to make sure I've got the correct amount of space, remove the old restorations, fit our prototypes, take our new impressions, and our technician will now start to make crowns that look like teeth. Okay, crowns that have the right shape, and this is so much important here. And we're creating crowns that have the correct width to length ratio. We are encouraging the soft tissue to come down by changing the emergence profile. Huge topic on its own, vertipreps, biological orientated preparation technique, changing emergence profiles. If you change emergence profiles in these areas, sub-emergence profiles, that's what we're talking about. The angle which the tooth comes out of the soft tissue at. Change it from the average 30 degrees to much flatter, we find that the soft tissue comes down. And this is how we now go and change our restorations from being ugly, not looking aesthetic, to teeth or crowns that look like natural teeth with the correct width to length ratio, the correct lengths, the correct golden proportion. And we got from 1.2 to 1.5 to 1. So we did a pretty good job. And again, in terms of golden proportion, we're in the right golden proportion. This is golden percentage, which is putting the proportion just into a percentage. And here's our golden proportion. So maxillary central incisors must be symmetrical. And here's a case that we can look at a little bit more closely. You can see the symmetry is wrong to start off with because this tooth is inclined badly. We've also got areas of erosion. We've got a crack in place. And we're going to go and change these. So we do two veneer preparations. We put our prototypes on. We manipulate our prototypes so they're the correct shapes. Now both of these teeth are absolutely symmetrical to each other. The center line's right. The width to length ratio is correct. And all we do now is go and change those prototypes to our final definitive restorations. And these are our two lovely veneers, matching the colors with the little tiny white flecks of the veneer with the natural teeth. And again, they're in the golden proportion, the correct width to length ratio, and both of the central incisors are absolutely exactly the same as central incisors should be. Another case, central incisors, patient wasn't told that the teeth would not bleach when had them bleached, and so straight away we've got bleached teeth and darkened centrals, and we're going to change these two restorations from old ceramics to new ceramics. And the first thing we do is we make sure that both centrals look exactly the same. We create something that looks natural. We recreate the ideal colors. So you can see that the natural teeth either side have got lots and lots of color in them, and we create the same colors in our beautiful ceramics. And this time we have a flat appearance, a much flatter appearance for a male person. Finally, our last case study before we finish and take some questions is lateral incisors. What do we know about lateral incisors? Well, the first thing we should know is they are a totally different shape. Not as much concavity, not as much convexity. And instead of being flat, we have a concave emergence profile mesially, so a completely different shape. Please always look at your restorations, and when your laterals and centrals come back, they should be different shapes. If they're not, it's going to look totally false. And within the same mouth, your lateral incisors will be different. The width will be different, the length will be different, the rotation. I like to look at this and say, this is the way we create personality of the smile. This is where I create sexiness in the smile and personality. And if we look at some of our actors, actresses, etc., J-Lo again, just look at J-Lo's teeth. Central incisors the same. Look at the laterals though, completely different. So in the same beautiful mouth, the laterals should be different if you want a natural smile. If you want the media smile, they've got to be the same, but that looks totally false. So we'll finish off with this case. Two ugly looking crowns, and let's go and make them look more natural. And here's our natural ceramic crowns. And what have we done differently? Well, let's just have a closer look up at these. And the things that you'll notice straight away, which I've done deliberately, is that we have a rounded incisal edge, we have a flat incisal edge. I rotate the upper right, in this case, by 30 degrees to the mesial, so it looks thinner mesiodistally. Upper left lateral incisor, I rotate 30 degrees forwards from the distal, so it looks wider. And we create two ceramic restorations which look completely different in the mouth. From that to this, and we're producing sexiness, we're producing personality in a smile. And I like to try to give a smile personality. I like to try to give a smile a little bit of cuteness, and that's what we're doing. To me, this is a beautiful, beautiful smile. It's not one of those wall-to-wall white. We're creating aesthetic dentistry here. And here's our final lady. So what we've done today, guys, in this very, very quick 1 hour program is we've gone through the basics of smile design. As some of you will know, I work in Dubai and the Middle East, throughout the Middle East, and we have a certificate and diploma course in restorative and aesthetic dentistry, and we cover smile design. We cover in much more detail. We have 2 full days of designing smiles, both media smiles and natural smiles, and going through this list in huge amounts of detail, so you know exactly how to create the natural smile. So if this is of interest to you, then please, we have a new course starting in a few weeks' time, and you can see some of the topics. Location, we're located in the center of Dubai. The course is a 15-day certificate followed by a 15-day diploma to get a BARD, British Academy of Restorative Dentistry certificate and diploma. These are some of the topics which we teach, and we have many, many people who, if you look at the slides here on the website, if you go to the CAP website, you'll find testimonials of what the course is all about. We would be delighted to have any of you join us. And from my point of view, I love coming to Dubai and teaching in Dubai, and would really, really enjoy the opportunity to come and help you get involved with smile design and to see you at some stage in the future. So I'm quite happy to take some questions now. If anybody would like to ask me some, I've set some time aside. If not, then I'll be very, very happy to see you at some stage in Dubai. So any questions, please ask away, guys. Dr. Zaha, very informative. Thanks, Professor. Thank you very much, Dr. Zahra. If you'd like to know more, then please come along and we can go into greater depths. So we have another question of how do we deal with TMJ pain following changes in vertical dimension? Big question, big answer. Number one, you will sort out the TMJ pain if there is any prior to doing the treatment. And of course, if you understand TMJ pain, what causes it, it's usually due to stress and bruxism, and the two combined in some way. And one of the usual treatments for TMJ pain or TMJ dysfunction is doing an occlusal splint. And with a maxillary occlusal splint or mandibular splint, usually they are made by the technician so that the splint is approximately 2 millimeters thick over the retruded contact position tooth. The retruded contact position tooth is usually a molar tooth, not always, usually a molar. And if you now make a splint which is 2 millimeters thick over the molars, it's approximately 6 millimeters thick at the front of the mouth. So what we've done with the occlusal splint is we've increased vertical dimension by 6 millimeters at the front of the mouth. But most importantly, we have put the condyles back in their correct position, RAP. And this is all that I'm going to be doing with the reconstruction at an increased vertical. With the occlusal splint, we've increased vertical dimension by 6 millimeters, and we've given what we would consider by today's standards a perfect occlusion, 5 principles of occlusion. When we do an increase in vertical dimension, we have to make sure there's no TMJ pain first of all. If there is, we treat with an occlusal splint, get rid of it. But we have no problems whatsoever with patients developing TMJ pain after treatment, because it won't happen. As long as we do our job correctly and increase the vertical dimension around retruded axis position, and we give the patient the 5 principles of occlusion on their new restorations, there'll be no TMJ pain. Thank you for your question. Another question from Dr. Zara. When to raise the bite? What should we be looking for guidelines? So raising the bite, increasing vertical dimension. As I mentioned in the previous answer, first of all, it has to be done with the condyles in the right position. So this means a reorganized approach. This means taking your patient back to retruded axis position, adjusting the teeth initially so that the condyles are stable in RAP and all the teeth are interdigitating. That's number 1 stage. Number 2 stage is then we open the patient up. And how much do we open them up by? I mentioned in our first part of the webinar today, we open them up so they are in the correct proportion. So we open them up, the lower vertical dimension is opened so it is the same vertical dimension as the middle part of the face and hopefully the upper part of the face. So we open up the vertical dimension by as much as we need to improve facial aesthetics. But it has to be done around retruded axis position. Otherwise, the temporomandibular joints and muscles will not tolerate it. So you have to understand occlusion. Very big part of my training program is about occlusion. If you don't get the occlusion right, you don't understand it, your restorative work will fail. End of story. So you have to take a time out. If you're a restorative dentist, go and learn and understand occlusion completely. This is what we teach, and then your restorative work will succeed. Okay, next question. Let's say the change in vertical dimension was not ideal, which caused the pain. Would you still go for occlusal splint first or directly consider retreatment? Okay, interesting. This would make me assume that you've got a case something similar. So vertical dimension has been increased, but there's pain. So in all probability, the condyles are not in the right position. So what we would do first of all is fit an occlusal splint. We would then adjust the occlusal splint over a period of time to get the muscles relaxed, to get rid of TMJ pain. This would allow the condyles to reseat in the right position. I would then remove the splint at one appointment and do an occlusal adjustment or equilibration so that the teeth fitted together with the condyles in the right position, and then we'd reassess. It may be that with just a little bit of occlusal adjustment, the previous reconstruction, the previous dental crowns will be fine. It may be that we have, with the occlusal adjustment, had to go through the occlusal surfaces of some crowns, or change the shape of them, or gone through until the opaque is showing. So it's very difficult to know. But initially we treat with occlusal splint, we get the patient comfortable, we'd reassess, and then either leave them on the splint or we would retreat our patients. Next question. Some practitioners suggest using a face bow every time you fabricate an indirect restoration, even a single crown. What is your opinion of this? I would agree, but I only agree it's not for any esoteric or scientific reason. It basically means that I have less adjustment time. So try to understand, if we do a restoration on a bona fide articulator, an articulator which mimics the movements of the mouth, then we'll have a better chance of getting that restoration more or less the right shape. If we don't do a restoration on an articulator, we have no ways of knowing the general shape of it, even if it just fits together with handheld casts. When the technician does handheld casts, he makes the restorations fit at 90 degrees to each other. But when we're in the mouth, our lower teeth don't hit our upper teeth at 90 degrees. They hit at an angle. Hence, we want to try to reproduce that angle on the articulator. The way we reproduce the angle that the lower teeth hit the upper teeth is by using a face bow. So the face bow gets me the angle of the lower teeth hitting the upper teeth. That then means that when I put the restorations in the mouth, there's less adjustment to do. And for me, if I can do the least amount chair side, then that's great. There's nothing worse in a patient's view of taking what looks like a perfectly good crown and then hacking it to bits, grinding lumps off it to try to get it to fit occlusally. So for me, yes, I take a face bow every single time I do an indirect restoration. It's more important at the back of the mouth. So the closer the tooth is to the hinge, okay, to where RAP, to terminal hinge axis, the more important it is that you take a face bow. So it's more important to take a face bow if you're doing a crown on an 8 than it is if you're doing a crown on a 4, simply because you'll have more adjustment to do to get the crown to fit occlusally on the 8 than you would do on the 4. And again, for anybody who's interested in occlusion, please come on some of our courses, because we will go through occlusion in great detail and the reasons why this is so important. There don't seem to be any further questions, so I'm going to sign off now. And thank you very much for listening. I hope you enjoyed it, and I'll be back soon with another webinar. Take care for now. Thank you very much indeed, everybody. Goodbye.